So it's 7:30. Today is May 13th, 2020. My name is Dr. Kevin Kim. Welcome to Yale Interventional Radiology Grand Rounds series. Today we have a special speaker, Dr. Alan Friedman. It's a pleasure to introduce Dr. Friedman. Dr. Friedman was born and raised in the state of Michigan. Dr. Friedman went to University of Michigan for his undergrad and medical school at Wayne State University in Detroit. Dr. Friedman continued his pediatrics training at the Northwestern University's Children's Memorial Hospital, finished chief residency, and came to Yale for his fellowship in pediatric cardiology, and has been at Yale ever since. He became the fellowship director in pediatric cardiology, as well as the director of a long-standing pediatric residency at Yale. Now, in addition to the national prominence in his innovative work, perhaps pertinent to his talk today, he has served in many of the crucial committees at Yale and the Yale New Haven Hospital. He served as a chair of CLEAR, the subcommittee within the safety committee of Yale New Haven Health, and he served the chairmanship in the mortality review committee at the Yale New Haven Hospital, chair of the medical staff's professional committee at the Yale New Haven Hospital, and recently he served as the president of Yale New Haven Hospital medical staffs, and currently he is a professor of cardiology at Yale School of Medicine and the chief medical experience officer for the Yale New Haven Health. His talk today is entitled "You Get the Dog You Can Live With," which is a very interesting title, building a culture of professionalism. I know that in addition to our Yale IR faculty and the trainees and our staff, but also our interventional radiology physicians and the staffs of the DNs within the system are joining. If you have questions, please put them on a chat box. And after about 45 minutes of a lecture, we will go over everyone's queries at the end of the grand round. Thank you so much for joining us, Dr. Friedman.
My pleasure. Thank you, Kevin. It really is great to be here with you, if not in person, at least virtually. So let's begin. I wanted to start this morning with a safety story, which we often do in our leadership meetings around the hospital. The story may sound familiar to some of you. It's about a patient who was scheduled to come to interventional radiology for a procedure. And when he arrived in the procedure suite, it was listed that he was due for a left-sided procedure. This raised the curiosity of one of the IR fellows who had previously understood that the procedure was in fact due to be a right-sided procedure. And the IR fellow and the staff in the lab appropriately stopped the line until they had clarity and certainty about what was done or what was intended to be done. And the chart was reviewed, calls were made to the inpatient team, attention to detail, and practicing safe and high quality care were instituted, and sure enough, the correct procedure was then performed on the proper side, which was the right side. I think that this story in so many ways speaks to our high reliability organization and the principles of high reliability. And it allows us to provide safe and high quality care for our patients. So as we begin, I just want to take a moment on behalf of all of us at the hospital, and I'm sure all of us in the interventional radiology group, to thank Taylor Powell and the folks who were in the procedure suite that day for paying attention to detail and doing the right thing. So thank you, Taylor, if you're on, and if you're not, we'll make sure to reach out and let you know. So I think Taylor's actions are a perfect segue for us to talk about culture. Culture is a little bit of a buzzword. We hear it a lot in the news, in the papers, in our daily lives. For the purposes of today, we'll refer to culture as the attitudes and behaviors. And I want to stress that attitudes are what we control about ourselves, and behaviors are in fact what we control about ourselves. So culture is the attitudes and behaviors that are characteristic of a particular group of people. And for our discussion today, the group of people is us. It's all of us as healthcare providers. It's all of us who work at Yale New Haven Hospital, or perhaps even at other delivery networks and other sites within the Yale New Haven health system. So Angel, who has been remarkable in helping me set this talk up from a technical standpoint, tells me that if you hit your space bar, you can answer the first of today's quiz questions. And the question is, what are we looking at? Does anybody want to take a shot? So in the absence of volunteers, I will tell you that this is the predecessor to Yale New Haven Hospital. This is what our hospital looked like in 1911. And if you direct your eye toward the just left of center, you'll see sort of a light white building with 4 columns in front. And for those of you who walk from Howard Avenue into the medical center, you can still see the facade of this part of the building when you come in. I also love this picture because in the foreground on the right is a dog, and he just appears to be happy as can be sitting out in front of the hospital. This, of course, is what our hospital, our medical center, looks like today. We are huge. You can see Smilo to the left, the Children's Hospital to the right, the South and East Pavilion form the other 2 corners around the atrium. And we work in a very challenging environment. Yale New Haven Hospital is one of the largest open hospitals in the country. And by open, that means that we have a full-time faculty, like most of us, I imagine, on the phone, docs who are in fact employed by the university, the medical school, and Yale Medicine. But we also have a very large practice in the community. We have a lot of non-Yale Medicine docs who work at Yale New Haven. We have over 4 million square feet of clinical space, about 1,500 plus beds. On a normal year, we have somewhere between 80 and 84,000 admissions per year. We see nearly 1.5 million outpatient visits every year. Our medical staff is one of the 4 or 5 largest in the country. We have about 4,500 members of our medical staff. We have a very large series of training programs throughout the organization with more than 1,300 residents and fellows. So this is a challenge for us to do anything in a highly organized and efficient way. And as a result, in 2013, we launched the campaign of high reliability. And as you can see from the bullet points on the left and the handy card that some of us carry in our coat pockets or in our shirt pocket or our white coat, we have what we call our CHAMP behaviors. And Taylor's attention to detail in the IR suite just a few days ago is a perfect example of what we call these CHAMP behaviors: communicating clearly, as we mentioned, the attention to detail, practicing a questioning attitude and arcing up questions when there's a concern. Now, to be sure, these behaviors help us have a safer hospital, but they are really strategies. These are strategies for how we can practice safe, high-quality medicine. My second question is, does anybody know who this person is? He has a very famous quote. He was an important leader in the business world from 1950 till about 2000. And again, because it's hard for us to communicate, I'm going to go ahead and tell you the answer. This is Peter Drucker, as I mentioned, widely regarded as a business leader. And he's famous for a number of reasons, but one of them is this expression that culture eats strategy for breakfast. So what does that mean? To me, working in this hospital every day, we have these strategies that we've mentioned, but if we don't have the right culture, then culture will gobble up and eat these strategies for breakfast, lunch, and dinner and spit them out. And no matter how diligent we are, if our culture doesn't support these strategies and behaviors, they won't be effective. So how do we think then about our culture? Well, several years after the institution of these CHAMP behaviors, we went ahead and decided that we would use the back of this little handy card and print our 5 core values for the health system in terms of our standard of professional behavior. And here they are. You can actually see this is my card that I carry around with me. It's dog-eared and bent at the bottom. But if we look at each one of these standards, you see patient-centered care, which is always putting patients and families first. You see respect, that we value all people, their diversity, their uniqueness, and their individual situations. We are compassionate, and we demonstrate empathy when we interact with each other, with our patients and their families. We have a sense of professional integrity as individuals, and our organization has a sense of integrity. And this means that we strive to do the right thing, even when the right thing is the hard thing to do. And finally, we have accountability. We are responsible for who we are and how we interact. We're responsible for what we say. We're responsible for what we do. And perhaps even more importantly, we're responsible for how we are perceived. We own the perceptions that people have of us. So I want to move to the second story of the day, and it takes us back about 5 years to the summer of 2015. And this is a story about a little baby who was born full term, but who soon after birth was identified as being quite cyanotic. And it turned out that she had incredibly complicated congenital heart disease with a single ventricle and limited pulmonary blood flow. She had a complex of disease that in congenital heart cardiology, we refer to as heterotaxy. And complicating her care was the fact that she was having intermittent supraventricular tachycardia, very fast heart rates that most children with a normal heart will tolerate quite well. This little baby did not tolerate it and did not respond to our first and second line medications. And so a decision was made to use amiodarone to control her heart rhythm. Amiodarone has side effects that I'm sure many here this morning are well aware of. In children, particularly with congenital heart disease, it can have deleterious side effects if it is given in too high of a dose or if it is given too quickly. Because of that, the attending and the fellow on cardiology that night decided to give half the loading dose and to give it well over an hour. So they took attention to use a smaller dose and give it slower. The orders were written. The discussion happened with the neonatal ICU. Nursing was on board. Everybody understood the plan. The baby then got the medicine. The SVT resolved, and soon thereafter, the baby became profoundly hypotensive and bradycardic and had a cardiac arrest. So how did that happen? We took great attention to detail. We practiced questioning attitude. We mentored each other, the M in CHAMP. We spoke about why it was so important to provide safe care. And yet this baby suffered a very serious untoward effect. And we were concerned that there could have been a medical error. I'm sure you're familiar with the Two Errors Human Report. It was published in November of 1999. It's hard to believe, but it's over 20 years. And this report, for those of us who were practicing then, was really stunning. In it, we learned that every year in our hospitals, we harm somewhere in the neighborhood of 100,000 people so severely that they have a catastrophic outcome, including loss of life. And I can tell you, when this report first came out, I was incredulous. I couldn't believe that this number of people died as the result of medical error. And for the following decade, there were a number of reports that sought to determine whether in fact this was true. Almost all of them showed that it was true, and where it may not have been was that it may have underestimated the number of people who die from medical error. More recently, just a couple of years ago from Johns Hopkins, this report was published by Macri, and in it he proposed that medical error in this country is the third leading cause of death. It's really a stunning statement if you think about it, trailing only heart disease and cancer. Now, to be sure, this report was quite controversial. The statistics were quite controversial, but the conclusions should impact us. We have to recognize that we harm patients, and we have to do whatever we can to avoid that harm. I want to fast forward to February of this year, and I'm sure for so many of us, the first day of February shown in the New York Times here seems now more than 3 months ago. It seems a lifetime ago. The newspaper that Saturday morning was largely dedicated to the impeachment of the president and what was going on in the Senate. But if you look toward the bottom left-hand side of the front page, you'll see this article about pharmacists warning that they're making fatal mistakes. And if we look at this paragraph in particular, we hear of how pharmacists are struggling to fill prescriptions, give flu shots, tend to their drive-through, answer the phone, work the cash register, counsel patients and call doctors and insurance companies, all while trying to meet corporate performance metrics. Now, this story is about pharmacists. They are our care partners. We've got dozens and dozens of pharmacists throughout our health system. They are integral to what we do. They are part of our team. But you could change, I think, you could change this story from being about pharmacists to being about physicians. It could be about nurses. It could be about the techs in our labs who help us do what we do. It could be about you, and it could be about me. We are all trying to do so much, so quickly, all day long, while trying to be productive, trying to be compassionate, empathic, trying to maintain our sense of integrity. Let's take a moment and just review what is it when we say a serious safety event. At the top of this triangle, we see that a serious safety event reaches the patient and results in moderate to severe harm or death. A serious safety event is like the event of the story of the little girl with congenital heart disease. Precursor safety events reach the patient, but they don't cause that catastrophic outcome. They don't have a lasting effect, and their harm is minimal, mild, or moderate. Near-miss safety events are the safety events that happen all day in a busy hospital like ours, and they are, in fact, the events that don't reach the patient. They are the events that the staff in the lab and Taylor detected and stopped before it affected the patient. We have serious safety events in this hospital. We have precursor safety events in this hospital. I told you the story of a serious safety event with a patient on our service. What do we say to families and to patients when we have caused them harm or caused a serious safety event? I think the answer is on the back of our card. It's really in the 3 core values of compassion, integrity, and accountability. And I want to tell you what we do in our hospital and our health system when we have a serious safety event or an unexpected, unanticipated event that causes harm to a patient. We refer to this process as disclosure. And we first learned of the concept just 3 weeks after the publication of the 2 Eras Human Report. It's quite remarkable how closely related in time these 2 publications are. This is a publication from a physician and a lawyer working together at the VA hospital, and they talk and put forward an approach to talking to patients after injury or unexpected outcome that involves an early injury review where there is a steadfast maintenance of the relationship between the doctor, the patient, and the hospital, with a full disclosure to patients who have been harmed. And when applicable, fair compensation to the patient or family for their injuries. At Yale New Haven Health, we refer to our disclosure program as the CLEAR program. CLEAR stands for Communication Leads to Early Resolution. And it is a communication principle that involves patients and families, and it's based on complete and open transparency, our sense of integrity, our commitment to be compassionate, and our sense of accountability. And it allows us to shift from the culture that I grew up in as a resident in the late 80s and a fellow in the early 90s, where when a mistake or error may have happened, the medical team and honestly the legal team circled the wagons. There was a sense of delay, deny, and defend. And we now have shifted from that approach to a real-time communication and collaboration. And what do I mean by that? We speak to our concern about the possibility for error. We speak as a team. We reach out to legal services. We reach out to our safety teams. We share the concerns that arise because as we learn from them, we share them across our departments, across our hospitals, so that an error that happens in the NICU, in the children's hospital, in the middle of the summer at 2 o'clock in the morning, can't happen in the South Pavilion on the 5th floor 2 years later. That's what we mean by communication and collaboration. Clear disclosure always begins with a sincere apology, and it's followed by a very explicit statement to the patient or family that an adverse outcome or an error has occurred. We talk clearly and transparently about what that error was, how and why we think it happened, and what we are doing to prevent recurrences. We know from our experience and from others what patients want to hear. There is no doubt that patients and families want to be addressed in a way that embodies compassion. They want to hear, and we should say, "I'm so sorry for what has happened to you." Now, I want to be clear here that when we say we're sorry for what has happened, this is not an admission of guilt. When we say we're sorry for what has happened or we're sorry for what you've experienced, that doesn't mean we've made a mistake. After all, we use compassion like this all the time in our lives. When we learn that a friend has had a serious illness or diagnosis, or that a relative or loved one has passed away, the first thing we say is, "I'm so sorry for your loss. I'm so sorry for what has happened." We use an expression of responsibility when we know that there has been an error, when we know by way of our review that we have made a mistake. In that case, we would say, "I'm so sorry for what you've experienced. I gave you the wrong dose of medicine, and that's why you've had this temporary kidney injury." We follow that up with this commitment, the commitment between us as the physician, the patient and their family, and really we're acting on behalf of our hospital. We made an error, or we've had an unexpected outcome. We don't know if it was an error or a rare side effect, but we will review what happened, and we will meet with you again to let you know what we find. This commitment is vital to the process of disclosure. Now, there are right ways and wrong ways to say, "I'm sorry." Most of us have learned that the hard way in our own lives. I will spare you the details, but this article from the New York Times Book Review was given to me by my wife. I thought she was giving it to me because I was preparing this talk. She looked at me like I was crazy, had no idea that I was preparing a talk. She gave it to me because she thinks I need to learn how to say "I'm sorry" better than I do. And I think she's no doubt right. We should never, when we apologize to a patient for an outcome they've had, we should never fail to take responsibility. We should not minimize the error. We should not say, "Well, I only gave you a little bit more contrast for your CT scan, and the effect on your kidneys is only going to last a week or so. It's really not a big deal." It is a big deal. That is a big deal to the patient and family. We shouldn't minimize, and we shouldn't normalize. Just because we work in this huge hospital and we have patients coming in and out of our IR suites all day and all night, we shouldn't normalize and tell a family, "Well, we take care of so many patients, this is bound to happen every now and then." That is not what patients should hear from us. And then, of course, we should never blame others. Whether the attending for that little baby gave the wrong medicine, whether the fellow wrote the wrong order, whether the pharmacist mixed up the medication incorrectly, or whether the bedside clinical nurse gave it in a way that it shouldn't have been given, doesn't matter. We made the mistake, and we should speak to our patients and families in the first person plural. We made the mistake. This is what disclosure looks like when it works well. The patient and family are in the center of everything we do. We start with that apology. We seek to learn, what does the patient and their family understand? We're going to speak and communicate in a language that makes good and easy sense for them. If they require a translator, we will provide an in-person translator, or we'll use one of the iPoles if it's a language that we can't support in person. We will then convey what we know to be fact in the moment, and what we don't know to be certain, we will continue to review so that we can provide that follow-up to the family. We will support the patient and family who have been injured, whether it was temporary or more permanently. And it's very important that we support our team. We provide peer support to our team, because when we're involved in a medical error that harms one of our patients, we ourselves can be injured, emotionally injured, and we must support each other. We speak to the plan, we make the commitment, and we meet with the family again, and we speak to them transparently. This is part of our culture. This is how and who we behave. So this is an example of how we talk to patients and families. I want to shift gears and talk about how we interact with one another every day. And I'll give you another patient story. This patient story came from our Department of Patient Relations. A family was very disappointed with the interaction that they were having with one of their doctors. They didn't feel that he was passing along all of the information, and they felt that their concerns were falling on, to use their quote, deaf ears. They felt that the care that was happening for their loved one was not occurring in a timely way. And every time they interacted with the doctor, they felt that he was dismissing them. They felt belittled and dismissed. So we did then what we do with every one of these concerns that comes to patient relations. Our superb patient relations team reached out to this doctor, and I have to tell you, 9 times out of 10, the physician hears these concerns, has a moment of reflection, and says, oh my gosh, I'm so sorry that the family felt this way. Let me give them a call. This doctor did the opposite. He denied the concerns. He expressed his frustrations. He got angry with patient relations. He was reluctant to work with the team. He didn't want to have a productive outcome. He didn't want to take care of this patient or work with this family anymore. So this takes us to the concept of self-governance, which is a really important part of who we are in the world of healthcare, whether we're a physician, a nurse, a sonographer, a tech. We have a sense of self-governance, and in the medical world, this is referred to as peer review. Peer review is the process. We'll talk about physician peer review, although nurses have peer review, medical students, residents have peer review. It's the process whereby we evaluate the quality of work of our colleagues. And I was surprised to learn that peer review actually was put forward as a requirement way back in the 1950s by by the organization called the Joint Commission on Accreditation of Healthcare Organizations. That name became JCAHO. Nowadays, they're referred to as the Joint Commission. So peer review was put in place in the 1950s, but it wasn't done well. And in 2007, the Joint Commission put forward updated medical standards that require peer review of every single hospital in the country. Whether you're a 60-bed hospital in rural Wyoming or a hospital in New Haven, Connecticut with 1,539 beds, both are required to have a peer review process to evaluate the quality of care provided by its medical staff. And I had the opportunity, really the privilege of chairing our practice peer review committee from 2012 to 2014. The committee used to be called the IPQPRC. We don't need to know those initials anymore. Now we call it the PPEC. It's the Professional Performance Evaluation Committee. And part of my duty as the chair of that committee was to review the nearly 250 or so cases that were presented by any pathway to this committee. Could be presented by other docs, by nurses, by students or residents, by families. Anyone who had a concern that the quality of care didn't meet our standards could bring a case for review. And our subcommittee would review these 250 cases. And one day, I sort of recognized that a small number, maybe 20 per year, were not about the sort of the smart medicine that was being delivered by these docs. These were concerns about the physician's behavior, the way he or she communicated, the way he or she interacted with the patient, the family, colleagues, or staff. And in a half-kidding way, I turned to one of my colleagues from Legal Risk Services, and I said, you know, these cases are a small number, but they take up about half of our time. We're going to need a separate committee to deal with these. And I thought I was just being a wise guy. She sort of smiled, laughed a little bit, and then about 2 weeks later called me to say, I've been thinking about what you said, and we should set up a peer review committee to evaluate professional behavior, not the clinical care delivered, but the professional behavior. And I learned two things from that. I was reminded it's very important to remember what you say and how you say it in front of a lawyer. And secondly, I learned that unfortunately in this country, there were almost no hospitals of certainly academic medical centers like ours that had a peer review process for professional behavior. So we were one of the first, and our committee launched in 2014. Why do we do this? Again, it's centered on our core values. We respect and value all people, and we should communicate with them in that way. We have a sense of integrity, and we're accountable, as I said at the outset, for what we say, what we do, and how it's perceived. We developed a charter for the Medical Staff Professionalism Committee. You can read it at the top of the screen. I can tell you that what we attempt to do is to stand up the Yale New Haven Medical Staff Code of Conduct. You may or may not know that we have a code of conduct. I'm going to show it to you in a minute, and I'm going to tell you where you can find it to read it. Our Medical Staff Professionalism Committee works in a completely confidential way. We try to work quickly. We have, because we are an open hospital, our committee consists of both full-time faculty and members of our medical staff from the community. We have no executive power. I want to repeat that. We have no executive power. We are not punitive. We don't tell people what to do. We make recommendations. We hope that our medical staff follows the recommendations. We have subcommittees that we call agent committees. The largest is in our perioperative service line. And our focus, again, is not to be punitive, but to work with our medical staff toward improved conduct and behavior that makes all of us proud. And we do so in a constructive and collaborative way. And we have an expression on our committee, and that is we try to use the lightest touch necessary in our recommendations to affect change. This is what our code of conduct looks like. It's a page and a half. It was written about 8 years ago, and you can find it on ynhh.org under the provider tab. It's the very first policy that you'll come across. I can summarize it for you. It's a page and a half of how to be a good human and how to be respectful, decent, and collaborative with everyone with whom we work and with everyone whom we treat. We made the reporting system easy. Again, multiple pathways to raise concern about the professional behaviors of our medical staff. It can come to me, it can come to legal risk, it can come through patient relations, it can come from any number of people, students, residents, fellows, nursing staff, pharmacy staff, chiefs of service, and it can come to us through RL Solutions. And when it does, it comes on my phone and it looks like this. This is a screenshot from last night or a couple of nights ago, and it shows that there are 2 concerns that have come through. With facial recognition, I'm able to get into the system and read the reviews. What do we do when we have a concern that comes to us? We respond to every concern. We become aware of the case. We log it into a central repository so that we have institutional memory. We then seek our medical staff's insights and reflections about how and why someone may have raised this concern to us. And again, I want to emphasize that we are not detectives. We do not go out and try to adjudicate what exactly was said and what exactly was done. Rather, we stick to this is how your behaviors were perceived. And we follow this, what we refer to as our intervention triangle or intervention pyramid. And for the typical raising of a voice or saying something that was viewed as dismissive or offensive, we start with a cup of coffee and we hear from the member of the medical staff, we hear from our colleague what they thought about what happened. We bring that back, present it to the committee. If the committee has additional recommendations, it often references the pyramid on the bottom right of the screen. If they agree that the case is, quote, closed, that the physician has had some reflection and insight, we move on. And like all of our medical staff committees, we report annually to the Medical Executive Committee. This Medical Staff Professionalism Committee is not a committee of the hospital. It's not a committee of the medical school. It's not a committee of Yale Medicine. It is a committee of our medical staff. When we send out a letter, it looks like this. The first paragraph tells the doc what our committee is all about. The second paragraph is a summary of what the concern was. You'll notice this letter is addressed to me and signed by me because I am fully aware as a practicing doc on our staff that something I say or on a day when I am not at my best, something I do might be perceived as unprofessional. And there may be a complaint someday that I open up on my phone and it's about me. It can happen to any of us. We're human. Again, we focus on the perception, our discussion is confidential, and we move on. It is our attempt to be better. I thought I would show you our 5-year running total. In year 1, we had about 20 concerns, just the same number that I mentioned that came directly to the MSPC. But as we stood up the perioperative committee, there were more concerns there. It's, as you can imagine, like your IR labs, there's a lot of intense work and there are vulnerable moments for our behaviors. In year 2, we saw about a 50% increase. In year 3, we saw even a greater increase. And then in year 4 and 5, the number of concerns that have come through our system have been relatively stable. Some look at this and say, well, geez, you roll out this committee and the behavior gets worse. That's possible. I think more likely we roll out the committee, and as our staff and colleagues and as it becomes part of our culture, we're more comfortable raising concerns. I think that we would be foolish to think that even in year 3 that we only had 150 concerns. I think we have far more than this. Most of them are handled in real time, but I would hope that as people are more comfortable with high reliability and more comfortable with how this committee works, that this too is part of our culture. In the interest of time, I won't ask this as a quiz question. I will tell you that this is Elizabeth Kubler-Ross. She wrote death and dying and taught us about the stages of grief that you see here. I've had now hundreds, several hundred cups of coffee, front line, first line conversations with medical staff who have had professionalism concerns. And I have come to the conclusion that our medical staff work through a fairly similar process. On the y-axis, I'm showing you energy, but I'm not putting any units there. On the x-axis, I'm showing you time, again, without units. Sometimes this process takes hours, literally. I send out the notification, my cell phone rings, the doc wants to talk, and within a few hours, the whole thing is resolved. Sometimes it takes days, weeks, and in rare circumstances, it takes months. What happens? Oftentimes, our medical staff begins the process with a sense of denial. When the concern is made clear to them, there is a little bit of, well, you know, I didn't say that, or I didn't say it that way. That's not what I meant. I didn't throw my mask on the nurse's desk. I said it there gently. A lot of denial. Sometimes this moves to anger. I have to tell you, though, I'm incredibly proud of our amazing medical staff. Almost always, I would say at least 95% of the time, that initial denial and anger moves to a place of reflection. And on my scorecard, when we get to a place of reflection, I count that as a win. If we're able to think back on how we might have been able to do something differently and perhaps better, that's exactly what our culture seeks to support. And most often when there's reflection, we get to that core value of accountability. Yeah, I didn't say exactly what they reported, or I didn't do exactly what the concern alleges, but you know, I did lose my temper. I could have done better. And most of the time, our docs want to take action. They want to apologize. They want to make good on what happened. In rare cases, they become a champion. And I want to go back to our patient's story and talk about that. I told you how it took months for this doc to become reflective, and that initially he wanted nothing to do with this. As a result, that case went to medical staff professionalism, and he demonstrated all of those stages that I just showed you. His denial and frustration gave way to reflection and accountability. He apologized, and he actually became a champion for the process, although it took about 6 months. He came to me and asked if he could give a Schwartz rounds where he would talk about the emotional experience he had in dealing with the family and then being asked to reflect on his behaviors, and wanted to give that grand rounds to his department. And again, I think that tells us about our culture. And finally, I want to go back to Saturday, February 1st. We talked about the politics on the front part of the page, the pharmacist on the bottom, the medical errors. Look to the bottom of the right of this front page, and sure enough, it was one of the very first reports of the health emergency, and this was the first action taken by our government to limit travel. And I don't have to tell you what has happened since. I'm on a daily, I spend most of my days dealing with COVID and working with our chief medical officers across the health system to do right by our medical staff. Every day I plot out what our census is and what our numbers are. You can see that we increased our COVID patient census in the month of April to a maximum of about 450. Our rate, our slope of increase is far steeper than our slope on the back end of the curve. I'm very happy to tell you that this morning, May 13th at 7 o'clock, we crossed below 300 patients. We have 298 patients in our hospital this morning, which is remarkable. On the right side of the screen, shown in royal blue, you see the admissions day over day, and in the lighter blue, you see the discharges. And not surprisingly, through much of April, we had more admissions than discharges. Now in May, almost every day, our discharges outnumber our admissions. So we are getting there. We are going to get through this. We are getting through it. This is what the health system numbers look like. We hear so much, both in politics and public health, about the COVID crisis. We have admitted more than 3,000 patients in the system, but I want to tell you that we have now discharged more than 2,300 patients alive. We all know that this is a deadly disease. We have had more than 420 deaths across the health system. Our COVID crisis, as I've shown you in graph, has statistics that are hard to believe. You know that we have rearranged our hospital. We have converted Smilo, our cancer hospital. At one point, of the 15 floors, all but one were COVID floors, either medical or ICU. We are now slowly beginning to reconvert those floors back to medical floors. Not only have our hospitals been rearranged, but our surgeries and procedures have been delayed and canceled. We have about 3,500 surgeries and procedures that have been postponed. So we're going to be busy in the coming months. Our staff assignments have changed. We had nurses from the adult service taking care of patients in the adult patients in the children's hospital. We had a pediatric service that moved to the adult hospital to take care of young adults with COVID. Our clinics, our practices, our teaching and ways of learning are completely altered. And our way of life for all of us, has been and continues to be upended. I'm always taken by the cover of the New Yorker. It seems so accurately in a cartoon or illustration to really embody what we experience. And this was the New Yorker from just a month ago. And I think it speaks to exactly how many of us have practiced. This is James Lane Allen, who more than just about 100 years ago said, adversity doesn't build character, it reveals it. I think for the purposes of today's presentation, I don't think he would mind if we altered his saying to adversity doesn't build culture, it reveals it. And I think among the many amazing acts that we have seen from our staff and our docs and our hospital, one of the most impressive that I think embodies all of our standards of behavior, or standards of professional behavior, is a program called Family Connect. Family Connect was presented to my office as an idea, the experience office, as an idea in early April. And because we have visitor restriction because of COVID, whereby families and loved ones can't visit sick patients in the hospital, and because our clinical teams are so busy on providing acute care for all patients, those with COVID and those who don't have it, there was a lack of communication between our medical teams and patients about how patients were, and families, about how patients were doing in the hospital. And we also know that some of the 4,500 members of our medical staff have not had an opportunity to work. If you're a dermatologist, if you're an ophthalmologist, if you're an ENT doc, your opportunity to see patients in your clinics has been severely hampered. So we have underutilized physicians and inadequate communication between our medical teams and patient families. And Family Connects brings these two groups together. We trained our underutilized docs to participate on rounds for our patients. They listen in by telephone. They then discuss with the care team by telephone or FaceTime, and then they call the patient family and give them a real-time update. and they do it early in the day. This is not meant to replace the communication that happens between the medical team and the family, but it's a way of bolstering and improving the communication and doing it in a more timely way and relieving some of the burden for our busy medical team so that they can continue to provide care. The program was conceived, developed, and deployed within 2 weeks, which is remarkable for anything to happen within 2 weeks in an organization this big. Again, I think it speaks to our culture. And I have to give a shout out to Dr. Brittany Branson from the Department of Radiology, who works with me here in patient and medical experience. Brittany took the lead on this program and really built it in this remarkable time course. She, along with our communication experts, developed a training module, implemented it, and have put 62 physicians through the system, 8 of whom, by the way, are from radiology. So shout out to your colleagues. They've provided more than 600 phone calls to families on more than 100 patients. And it has really connected our teams to our families in a way that we never would have guessed before this crisis. Just yesterday in one of our conferences, one of my colleagues said, in reference to this, it took a pandemic to get our communications right. And, you know, I think it's true. And I think it is now incumbent upon us to make sure that the systems and programs and approaches that we've developed for dealing with this crisis, those that work well, we need to carry forward as the crisis moves behind us. Here's the front page of your Yale Medicine Radiology and Biomedical Imaging website. It shows one of your colleagues participating in this program, which really speaks to our collective imagination, innovation, and integrity. So I'll close by telling you why the title. These are our 2 dogs. Milo is on the left, Apache is on the right. Milo is an Australian Shepherd rescue. Apache is a Corgi mix rescue. And this is where my wife wants the dogs to be. She wants them to be on the floor. This is where the dogs want to be. They want to be on the furniture. So my wife decided we were getting a dog trainer. He lives in Milford. He charges in 15-minute increments. He comes to the house. He's, in my opinion, always seems to find the days with the busiest traffic to make the trip. He's expensive. He comes to the house. The dogs get off the couch. They look like the picture on the left. They stay this way for a few days, and then they're back on the furniture. We call him back. He comes back out. He trains the dog. He helps train us. And for a few days, the dogs stay on the floor. On his 3rd or 4th visit to us, my wife looked at him and said, they keep getting on the furniture. Why do they do this when, you know, when we're here alone, but they don't do it when you're here? And he looked at us and he said, Jennifer, you get the dog you can live with. And I didn't realize it at the time, but what he was telling us is that we can have all the strategies around the way we train the dogs. But if the culture in the house allows the dogs on the furniture, if the kids allow the dogs on the furniture, if Jennifer's husband, that would be me, allows the dogs on the furniture, then that's the culture. And no matter what your strategies are, the culture will eat those strategies up. So again, we control our attitudes and behavior. We control our culture. The culture that we have is the culture we can live with. I'm incredibly proud of the culture we have in our hospital. And I want to thank you for bearing with me this morning for a talk that I wish was in person, but we've had to alter, be imaginative, and innovate. Thank you.
Thank you. Thank you so much, Dr. Friedman. This talk was actually arranged well before in advance to COVID-19. So of course, COVID-19 changed a lot. May I ask the there was a training program for everyone from the CLEAR program. Could you tell us the updates on the training program?
Yeah, so thank you. That's a great question. CLEAR is now 4 years old. We have trained more than 100 physicians and staff across our health system as coaches for CLEAR. It is very hard to have these conversations, particularly when we have the relationship between the physician and the family and the patient. It's very hard to sit down with someone and tell them that a medical error has caused harm. We rely on our coaches to help get us through, to remind us the best ways to speak to families after medical error, to help us be aware of where the vulnerabilities are. And the coaches can also identify ways in which we can support each other. The CLEAR program trains coaches on an annual basis to continue to grow our CLEAR coaching staff. So I would certainly encourage anyone here this morning who's interested to let us know. We'd be delighted to have you join us. You can access a CLEAR coach easily on the medical staff portal or any of our clinical workstations by typing in CLEAR disclosure.
Thank you. Thank you very much, Dr. Friedman, for the fantastic talk. So that concludes today's Yale IR grand rounds. Thanks everyone for joining us. Thanks a lot.
Thank you.
Thank you.